Dear colleagues, we would like to present case report of the surgical treatment persisting optic disc pit maculopathy with concentrate of autologous growth factors embedded in a fibrin matrix. Female, 32 years old, with unilateral ODPM and BCVA 0.2. Extent of the fluid associated with the pit was inside of the main maculovascular arcades. The location of the fluid was classed as a combination of multilayered intraretinal fluid and subretinal fluid with outer retinal layer defect. Central retinal thickness was 1540 microns. On the optic disc we observed some signs of traction and valve-like structures. The surgical plan was to remove posterior hyaloid, peel ILM, cover the optic disc defect with pre-flap ILM, air fluid exchange and 20% SF6 gas. No laser, no drainage retinotomy was used. Pars plana 25 gauge vitrectomy was performed and posterior hyaloid cortex was elevated by progressive aspiration and removed to the equator. ILM was peeled after staining by membrane blue dual. Free ILM flap of about 1 disc diameter size was additionally peeled and put into optic nerve pit to block fluid flow. Some remnant of fibrous tissue was removed from optic disc head with forceps. During air fluid exchange, backflash cannula was placed peripapillary to decrease the risk of displacement ILM flap. 20% SF6 gas was injected at the finish of the operation and patient was asked to keep head down position for 4-5 days. After gas reabsorption, OCT revealed persisting but decreasing height macular detachment with improving visual acuity to 0.3. During subsequent 6 months, the situation has worsened. Central retinal thickness was increased to 1330 microns, with visual impairment to 0.15, and we also observed the extension of the fluid associated with the pit beyond the inferior macular vascular arcades. No flap ILM was visible in the optical coherence tomography and fundus images. Repeated surgery was performed for persistent submacular fluid, during which we planed. Peel one more free flap ILM and fix it on optic disc pit with concentrate of autologous growth factors embedded in a fibrin matrix. We suggest that the combination of growth factors and fibrin allowed to rely not only on a temporal adhesive effect caused by the fibrin, but also on a permanent repair of the nerve defect stimulated by growth factors. The ILM flap could be used as a matrix. We performed 25 gauge approach using additional lighting. Membrane blue duo was used to dye ILM, but we tried to avoid getting dye on a previously ILM peeled retina. ILM flap of about 1 disc diameter size was peeled almost completely. Retinotomy and air fluid exchange with maximum drainage of subretinal fluid and optic disc pit fluid was performed. 2 drops of the previously prepared concentrate of autologous growth factors embedded in a fibrin matrix were applied to the optic disc pit in air-filled eye. Prepared ILM flap was moved to the optic disc pit. Unfortunately, even by manually, it was impossible to fix flap in correct position in fibrin envelopment. After several attempts, ILM flap was removed. No laser and no gas were used. In a few minutes, we observed organized clot in macula area. The patient was asked to keep prone position only 2-3 days after the operation to save clear lens. In post-op period, OCT revealed complete reabsorption intra and subretinal fluid with small amount of residual intraretinal fluid and outer retinal layer defect. Visual acuity improved to 0.5. It should be noted that in early postoperative period, we observed mild anterior inflammation which treated by steroid drops and solitary intraretinal hemorrhage in the middle of the retina, which resolved in a few months. We also marked spontaneous ILM detachment and absolutely intact healing of retinotomy site. We did not notice any substantial difference in post-op OCT optic nerve pit except for the lack of traction. Stability of the results was confirmed during follow-up visits. Thank you for your attention.